let me engage Dr. Kim again. With all the things that can be confused with this entity, and as rare as this is, can you sort of give us some of your perspective on the clinical radiographic differential diagnosis? What could be the possible confusing entities that someone might get distracted with from a, in a legitimate manner because of overlapping features?
Yeah, no, absolutely. Yeah. So, yeah, I mean, the first thing that comes to mind is not TGCT in all these patients, right? I mean, as Dr. Abraham said, we just talk about the more common things. So patients who have history of gout, certainly gouty tophi in the distal extremities is certainly something that needs to be thought about, because they also present with what appears to be swollen joints that are very, very painful. But they have a history of gout, so that can kind of help you delineate that a little bit. The more common things that we also think about is the rheumatoid arthritis. We certainly have seen rheumatoid arthritis be significant with significant synovitis and actually be confused for TGCT. There are very rarely intra-articular sarcomas. So those should not be ruled out as a possibility, although exceedingly rare. When it comes to metastasis for other malignancies, sometimes because the PVNS or TUCT can be very large and can actually have a very brownish appearance and kind of pigmented. In sort of superficial joints in the really distal extremities, sometimes you get kind of a brownish color around them. There are people who have discussed the metastatic melanoma as being on a differential diagnosis, although pretty rare, especially in the joint. But I think it's something you got to think about. Certainly, chronic infections of the joints can cause a very large synovitis and synovial hypertrophy. Lyme disease is certainly something that needs to be considered in that realm. And then just a chronic infection causing synovitis. So those would be sort of the clinical differential diagnosis that you would want to think about. Radiologically, what you have is a lot of times on X-ray, you'll see some joint erosion or joint injury. So in terms of radiologic diagnosis, especially in the distal extremities, in the hands and the feet, you got to think about calcific tendonitis, if there is a calcium deposition within the X-ray. So you can sometimes see that on the X-ray. In the joint, the other process that we can see a lot of is synovial chondromatosis, where you see a lot of different small, little, and large masses within the intra-articular space. But those have a very characteristic MRI signal. So it's not as easily confused with that compared to like a rheumatoid arthritis. I don't order off the bat the immunohistochemical stains. Generally, it's done by the pathologist. But when you look at some of the studies, looking at the immunohistochemical profiles of these tumors, CD68 and CD163 are certainly stains that are utilized by our colleagues and in research to look at how the macrophages, which are a key component of this tumor, express the findings that have led to the discovery of new drugs for this tumor entity. So that's how I would go about kind of evaluating and looking at these differential diagnoses.